So thank you so much for inviting me. And once again, very sorry not to be here. So I'm going to speak about the management of high-risk localized disease in 2024. This is a topic which is heavily discussed. So here are my conflict of interest. I'm actually a urologist in Brüssel, Belgium, but I still do clinic and surgery 3 days a week, but I spend my life doing a lot of clinical trials. So I have a lot of conflict of interest, but here it's about localized disease and it's my view of the disease, so don't worry. So when you speak about localized disease, you have to realize that you have basically two groups of patients. You have the patient with very low risk, intermediate risk, and patient with high risk and very high risk. And why is there two different color? It's really because the goal for this patient is totally different. And actually, you can see that if you look at the rate of death of these different cancer. If you look at the proportion of these patients, you see what is the proportion of the cancer diagnosis. You see that overall, low, favorable, and favorable intermediate, that's roughly 70%. And you see that actually, if you look at the person, the risk of death at 10 years, prostate cancer specific mortality, you see it is very, very low. Less than 5% of the patient will die from the disease, where in the high and very high risk group, they're not necessarily a majority of patients, but the risk of death is very significant. So basically, you can divide in two, like I said. You can take the very low risk, intermediate risk, and say in these patients, actually the goal is not to make them live longer because they're not going to die from the cancer anyway. And I really believe that for all these patients, active surveillance should be the rule, and there should be some exception for which we would recommend treatment. I believe that for very low risk and low risk, it's going better. There's more and more active surveillance. There's not still a lot of active surveillance in intermediate cancer, but I think it's the next risk. The high risk patient, which we're going to speak about now, it's totally different history. These patients, although they represent 25, 30, 40% of the patient, depending where you live, they have a risk of biochemical failure after local treatment up to 70%. And basically, they have a cancer-related death up to 40%. And they may only represent 20% of the cancer, but they represent 60% of all the prostate cancer deaths. So really, the goal in these patients is to be better. And so the question is, what local treatment? What adjuvant treatment? What about treatment escalation? Which patient needs more than what we give now? That's another way to see it. In red, you've got the very high and the high here, 20%. But if you look at the mortality at 5 years, they represent the vast majority of the mortality at 5 years. So, first question, are these patients still candidates for local treatment, or should we say no, there is no use of surgery, radiotherapy, we should go right away to hormone therapy? The answer is no. And actually, that question has been answered mostly in Nordic country and the SPCG7 trial published in 2009, where they took patients with locally advanced, high-risk localized disease, and they randomized the patient hormone therapy plus radiotherapy versus hormone therapy alone. And it clearly shown that the risk of death is much lower if you receive radiotherapy on the prostate. These data have been confirmed, like recently, by the Stampede group in the UK, who looked back at the non-metastatic patient with or without lymph nodes and showed that the patient did much better if they had radiotherapy on the prostate versus those who had only systemic treatment, such as hormone therapy or hormone therapy plus chemotherapy. So that's the first question. local treatment increase overall survival in high-risk patients. So these patients, they need to have local treatment. But then, what local treatment? As you understood from the previous presentation, there is no a big fight between advanced radiotherapy using very sophisticated radiotherapy and the robot. So clearly, should we recommend surgery or should we recommend radiotherapy? That's the number one question. And to be honest, there is no properly designed randomized controlled trial to claim that one treatment is oncologically superior to another. What do the guidelines say? We are in Europe, we follow the EAU guidelines, and you're going to see that, honestly, they're not really helpful. What they say is that you should offer radical prostatectomy to selected patients as part of a potential multimodality therapy. Basically, it doesn't mean anything. It doesn't say which patient, and it doesn't say what multimodal therapy. They should get an extensive lymph node dissection, and basically, radiotherapy should be complemented with androgen deprivation therapy or with a brachytherapy boost. However, they do re-insist that you should not recommend androgen deprivation therapy to patients which are not candidate for local treatment or doesn't want to receive it because it won't increase their overall survival. So let's look at the other side of the ocean, the American guidelines. It's exactly the same. They say if you have a high or very high, it should be external beam or radiotherapy, external beam plus ADT, brachytherapy, abiraterone. So honestly, you should understand the difficulty that the physicians are facing because in the very important questions such as which treatment should you recommend, which one is the best? So you just had, and I listened to it, a very, very nice presentation on radiotherapy. So the question is surgery still relevant to the high-risk localized disease? This is a topic with a few colleagues from Europe. We have investigated in depth with a group called IMPACT, where we have put together a lot of patients with high-risk disease who have been treated by surgery. First observation, actually, surgery do well. If you look at 10 years, and you look at the cancer-specific survival, at 10 years, less than 5% of the patient have died from the prostate cancer. You could say, oh, in terms of overall survival, indeed, surgery is a very good option. At 5 years, it's 96.4%, and at 10 years, 91.3%. But actually, if you look in the detail, surgery will be a good option only if you have a good prognostic high-risk disease, meaning you had either a PSA above 20 or a stage CT3T4 or a Gleason 8 or 10. If you have only one of these criteria, you're going to do well. If you have only the PSA and the CT3-4, you're going to do well. But if you multiply the poor risk factor, like you have all the risk factor or high risk, Gleason 810, PSA above 20, stage C3, you're not going to do well. So this is where you can answer the guidelines and say, who are the selected patients that would be good candidate for surgery? Really, these are the patients with one, maximum two, but not the Gleason score risk factor. And then something very important, because I see many second opinion, and the patient come to me and say, okay, I saw the doctor and he told me we're going to we're going to remove your prostate, so you're going to be fine, the cancer will be gone. No, that is true if you have low or intermediate risk factor. But if you have high risk factor, don't be misled. Surgery alone will not be enough. And if you look at the cumulative incidence of biochemical failure, meaning the risk that your PSA will rise anyway after the surgery, this is very significant. It's up to 40%. And many times, unfortunately, patients don't see really that when they go for surgery for a high-risk disease, they have inside of them that idea that I'm going to get my prostate out, so I'm going to be happy. I'm going to get rid of the treatment. And so, no, that's not this. This is what multimodality means. It means that if you choose surgery for a high-risk disease, the chance that you're going to be okay for the rest of your life is around 50%, no more, and that's important. You can actually calculate that more precisely. And I use this with my patient when I discuss the different options. This is the MSKCC, Memorial Sloan Kettering Cancer Center, pre-radical prostatectomy nomogram. Basically, you enter the characteristic of your patient, 65 years old. He had a PSA at 17. It was a T2A, just a small nodule, but a Gleason 8. If you look at the progression-free probability, so the chance you're never going to experience a rise in PSA, this is only 30% at 5 years and 22% at 10 years. And if you take a patient with a triple category, PSA 23, Gleason 9 T3A, you see it's more than 90% will have a PSA failure. So the patient should be really advised that if he goes for surgery, it is going to be surgery followed at some point within 5 to 10 years by salvage radiotherapy. That's important. So surgery indeed remains an option in selected patients who have been informed of the risk of recurrence. What about external beam radiation therapy? External beam radiation therapy alone doesn't work very well. In high-risk disease, you have to add hormone therapy for a certain duration. We're going to say 6 months to 3 years. That was actually shown a long time ago by 2 trials, an EORTC trial called the Michel Bola trial and an American trial called the Pilipich trial, where they gave radiotherapy to the patient and compare without hormone therapy with 3 years of hormone therapy. And you see, you reduce the risk of death by 50%. So if you go for radiotherapy, the patient also has to be informed. This is not radiotherapy. It's radiotherapy plus hormone therapy with all the detriments of radiotherapy. This is why in Europe, in many countries like Belgium, to avoid the consequence of suppressing the testosterone, we have been using bicalutamide 150 that had been tested in a trial when it showed comparable result to the LHRH agonist. Since then, there have been many trials. They all confirm that adding hormone therapy on ADT, androgen deprivation therapy, on top of radiotherapy increase the chance of being alive or free of metastasis by roughly 10% at 10 years. So that's a very significant benefit. The question is there a group that benefit more than another? Not clearly. Everybody seems to benefit at least from a little bit of hormone therapy. But not everybody benefit of a long-term hormone therapy. Traditionally, we have been giving 3 years, but this was demonstrated on trial that use old-fashioned radiotherapy. As you understood from the previous lecture on radiotherapy, radiotherapy has improved a lot. Higher doses are nowadays administered, and the added benefit of prolonging the hormone therapy beyond 6 months is not that great as it was before. And I like very much that very nice study coming from Australia when they look at the risk reduction. So how much do you reduce the risk of death by prolonging the duration of hormone therapy? And you see that most of the benefit come from the first year. And then indeed, you are adding a little bit of benefit, but not the most come from 6 months and 12 months. So when I discuss radiotherapy and hormone therapy with one of my patients, I will always say, listen, we're going to start by 6 months of treatment. And then we're going to go to 12 months. And then if you go very well, we may go up to 2 or 3 years. But if the patient is experiencing several, severe side effect, we will stop the treatment after 6 or 12 months. A very important myth and an argument that is many times and often used by the urologists when they discuss the treatment of high-risk localized disease is to say, listen, if you do a prostatectomy and then after your PSA rise, I can still do surgery on you. But if I do radiotherapy and thereafter you do progress, we're not going to be able to do surgery on you. First of all, conceptually, it is not absolutely correct. It is especially true for brachytherapy, but you can still do a prostatectomy after radiotherapy where you're going to get more side effect. But the question is, if your PSA rise, does it mean that you have a local recurrence and that you're going to need a second line of surgery? Actually, not frequently. If you look at high-risk patients, the proportion of local failure is only 13%, where the risk of distant metastasis is 21%. So pure local failure is it is not as frequent as the surgeon would like to say to justify using prostatectomy. A very important feature, however, is that if you have severe comorbidities, if unfortunately you already have diabetes, hemiplegia, leukemia, whatever, you will not benefit from additional hormone therapy. So that's very important. Prostate cancer is a cancer that emerged in many a time in the 60s, 70s. Patient may have a lot of other comorbidity. They should be reassured that you should not increase these comorbidity, because what you want is not cure their prostate cancer, it's cure them for a maximum of disease you can. So external beam radiation therapy and 18 to 36 neoadjuvant ADT is the standard of care for high-risk localized disease. But then, how do you choose? Once again, we are back to basic. How do you choose between the treatment? In terms of efficacy, there is not a single trial that can tell you that one is better than the other. We don't have direct comparative data in high-risk patients, but we have direct comparative data in low and intermediate risk disease. This is the very famous PROTECT trial. And you see that if you look now at 17 years, there is no difference between prostatectomy and radiotherapy. So we don't have a single trial saying one is better than the other. What is very different, however, is the toxicity profile. And basically, when you administer local treatment, you have 3 different toxicities. You can have incontinence, you can have rectal problem, and you can have erectile dysfunction. So overall, what is the signature of surgery versus radiotherapy? The signature of surgery is to cause more incontinence. These are the results from the PACE-A randomized trial. Small number of patients that are randomized to prostatectomy or stereotactic radiation therapy clearly show that incontinence is not the rule with radiotherapy. It is extremely frequent just after surgery and then improve over time. Very important in that trial, they decided to use a very strict definition of incontinence, meaning you can't not wear any protection after surgery. Where most of the modern series of surgery, for instance, they consider that wearing one pad is not really incontinence. The signature of radiotherapy is rectal problem. So if you look at the bowel bother scale, so how much are you bothered by your feces and by your rectal function, clearly this is the signature of radiotherapy. And clearly, once again, if you use a very strict definition, it is quite frequent. 1 patient out of 3 or 4 will report bothering from its rectum after radiotherapy. And finally, sexual function. clearly also in the favor of prostatectomy, where despite using the robot, despite using nerve sparing technology, still a lot of patients will experience erectile dysfunction. Which one is the more important? Rectal, incontinence, or sexual? That's very interesting because that's a very nice study conducted by Europa Uomo, the UPROM study. I love that trial because basically they ask the patient themselves, they send a quality of life questionnaire and ask the patient how he was, what he feel. And actually, if you look at what is affecting the most your quality of life, it's by far the sexual function. So although we should pay attention to that. It's not us to decide what is important. And if you see, as regard to continence, clearly, and these patients were operated from a few months to a few years or had radiotherapy the same, you see that clearly it is prostatectomy, either after a period of active surveillance or alone or with radiotherapy, which is affecting the continence the most. And if you look at what proportion of the patient still lack urinary control, so patient who still drip from time to time, it is clearly 18%, where after radiotherapy it's 10%. You basically double the proportion with surgery. In all this study, there is something which is missing, which is extremely important, which is what was the starting point. It is clear that the impact of a prostatectomy or radiotherapy will be totally different if you are 55 years old, you have a normal sexual function, or you are 82 years old and your sexual function is unfortunately already altered. In contrast to what is believed, it is actually the patient with the best sexual function at start who are going to suffer the most from radical prostatectomy and also radiotherapy in comparison to active surveillance. So clearly, the only treatment that do respect sexual function is to do nothing, but unfortunately is not an option in high-risk disease. And actually the same goes for incontinence. Did you have urinary symptom to start with? Did you lose urine to start with? This is a very, very interesting study. It's called the CESAR prostate cancer study. It is online. You can go online, enter your different characteristic, and it's going to make you an individual prediction of what should you expect in terms of sex, urinary incontinence, irritation, bowel function, hormonal symptoms, and compare radiotherapy, surgery, and active. I found that super useful with my patient because they can enter their characteristic and have a prediction which is done on a very large number of patients. So there is no better treatment. It has to be tailored to patient expectation. I usually tell my patient I have two robot portrait. The first one is the guy, he say, I want to get my prostate out. I would be more reassured. I understand there is a risk of radiotherapy. Sexual function to me, it's not a problem. And I would, and you know, I'm okay to wear one or two pads. And beside that, you have the patient who say, no. My quality of life, this is the most important. I don't want this. I want to go to something that will respect a little bit more my quality of life. So, and I can tell you, usually when you approach this like this, it's going to be 50-50. Is it going to change? What is changing? And the technology is changing. You had a nice lecture on radiotherapy. The way we do hormone therapy also is changing. What we have shown now is that if you have a very aggressive prostate cancer, a simple hormone therapy should not be given anymore. It should be combined with what we call AR pathway inhibitor, abiraterone at the moment. And if you combine androgen deprivation therapy like it was before and abiraterone, once again, you double the benefit. So keep in mind, if you do radiotherapy alone versus radiotherapy plus ADT, you double the benefit. If you do radiotherapy plus ADT plus abiraterone, you double the benefit again. And look here, this is the overall survival. Look here, 80% at 10 years with a very simple treatment. So clearly, we come to the point where we can say with a simple treatment and 2 years of hormone therapy, we're going to cure a lot of patients. Look at the proportion without metastasis. we have increased by 12%. So gain by gain, we're making that disease chronic. So today it is recognized by the guidelines. If you have very high-risk disease, you should get 2 years of abiraterone. Coming soon, in more high-risk patients, the benefit of enzalutamide, apalutamide, darolutamide, I'm sure it will totally change once again the management of these patients, and we're going to get more and more benefit. Finally, what's going to be the future? The future will be genetic, artificial intelligence used to pathology. You had a nice lecture on this, and new imaging technology. Look at the benefit of using a simple genetic score like the Decipher score. It's broadly available. It's still expensive in Europe, but it's going to come. You can much better classify the patient with high-risk disease. And you can also look at, is there really a benefit of hormone therapy? These are patients who had a prostatectomy, had PSA recurrence, receive radiotherapy and hormone therapy. You see that if you have a low genetic score, you have no benefit of hormone therapy. If you have a high genetic score, you have a big benefit for hormone therapy. So these tests will help us to inform who needs hormone therapy. I will go very quickly to AI pathology.
Okay.
It is the same. You have no pathological signature that will be used. Finally, the last big transformation will be using modern imaging technology such as PET PSMA. They are clearly changing the way we see the patient. And you see you can classify patient, no bone metastases, few lymph node, small bone metastasis. And using this, you can better tailor your procedure. So I really believe that the treatment will improve. The most important choice as a patient is to choose between surgery and radiotherapy, and the future is very interesting with a lot of development. Thank you very much for your attention.